Hello all and welcome back. Today we have the pleasure of interviewing Richard Pittman, who was the chair of the medicine clerkship for 7 years and has recently taken over the medicine sub-internship. Hi, Dr. Pittman.
Hi, Mikhail.
What are you teaching these medical students? It takes them half an hour to finish a presentation, and they still get the wrong differential diagnosis.
Well, I know it can seem like a long time. We actually tell the students by the time they do their oral presentation, have it down to 7 minutes, and that requires them to cut some things. However, I know that it can feel like a long time, especially when you've got a busy service and a lot of things going on in your brain. I value hearing the long-form student presentation and actually seeing the interns do it sometimes too, because I think we need to know that they're able to collect all that information. But if you really want to cut to the chase, okay, and know what they're thinking and really be able to focus your teaching on a specific patient, I recommend really focusing in on the assessment statement. We actually teach a really formulaic approach for the medical students on the assessment statement that I actually grade them on in the specific components by the time they present their write-up and their oral presentation, and I think it can be a useful tool out on the wards. Let me show you the formula, if that's okay.
All right.
Okay, here's the formula. So for an assessment statement, the formula should start with identifying info about the patient. 56-year-old man with diabetes and hypertension, example. They should mention the key history on which the case turned for them. So the key elements of the history that were really the most helpful, the key exam. And this is something that students sometimes, and interns and residents, actually forget to mention. Even if it's a normal exam, that can tell you something, but they sometimes don't talk about that. And then the key data, and then you finished with most consistent with. Okay, so let me give you an example in another color, that this would be a 34-year-old male with type 1 diabetes, and sometimes they'll say modifying things like the last A1C was 12, here with abdominal pain, polys, after running out of their insulin times 3 days. On exam, they have volume depletion and increased respiratory rate. The key data might be that they have a glucose of 600 and an high anion gap metabolic acidosis with a positive beta hydroxy. And then they would finish with, this is most consistent with DKA secondary to non-adherence with treatment regimen. Now, so this is the formula that we tell them to go through. Identifying info, key history, key exam, key data, most consistent with. So how can this help you out on the wards? Well, actually, after I've heard a long-form presentation and make sure they can do it, and sometimes with interns when we're really busy, I'll say, just give me your assessment statement in this formula. And what happens is when they start telling me about a patient, and they say, okay, this patient has heart failure, and they fail to mention any of the history things. We know they have heart failure already, and the patient probably has heart failure, but in the history, they should be figuring out, why do they have heart failure now? And if they don't tell me that in that key history, they either didn't collect it or they don't understand it's important. Another thing is, on a heart failure patient, for example, they may say they have orthopnea, P&D, but normal JVP and S3 and no S3, and there's no crackles, and all they have is lower extremity edema. And I'm like, wait a second. There's a lot of reasons you could have lower extremity edema besides heart failure, and I know that we need to go to the bedside and really focus on the exam on this patient. Or another one would be the data. Let's say, unfortunately, is that they take you don't get much in the history. It's like some vague pleuritic chest pain. The exam is normal, and maybe they even forget to say it. And then they say they got a CT-PE, and there's a small subsegmental PE, so most consistent with the PE. And you know that they have actually put way too much emphasis on the data they collected, and they haven't really thought about the story, the history, the exam, and maybe they're actually feeding forward something they got from the emergency department, which can be right, but we should all be suspicious of that and come up with our own conclusions. So anyway, this is a quick way that I can use a formulaic approach to the assessment statement to really understand how they've collected their data. Now the challenge to it sometimes can be, especially with interns or a new student, they don't understand the formula. So I actually do spend time during orientation to my team telling them this is the formula that I want to use, and that I will allow them sometime to just present that on a patient, especially if we're busy, so we can really cut to the chase on their decision making. I tell them I expect you to have squeezed the history for all that it can tell you, and to really answer the question of either what's going on or why now, to squeeze the exam and to say, hey, what did it really tell me? Even if that means the exam was normal and that's reassuring, and then the data, and then they have to commit. One thing Dr. Lubin does differently and that some attendings do is that Dr. Lubin likes them to say, I think this patient has bang, and start this whole assessment statement with what they think it is. And I really don't care about that, but this is the formula that we've been using for a few years with our students, and I think it's working pretty well.
So you're saying if I invest a little time at the beginning, that I could save some time when they present and really push them to tell me what they're really thinking.
Yeah, and I'm not saying get rid of the long form presentation, but I think that if you'll really focus in, and maybe if unfortunately if your brain has wandered during their presentation, if you really kind of wake up again right when they're about to do the assessment statement. I'm not encouraging sleeping during the presentation, but that this will really give you an important window into their interpretation of what's going on, and especially if you've given them that sort of skill to make sure they know how to do it.
Okay. Well, thank you so much.
My pleasure. Have fun on the wards.
Thank you.